Hi everyone, sorry for the earlier technical difficulty. What's happened? So hopefully everyone can hear that and everyone can see this all right. So my name's Patrick from Physio in Letterkenny, and I've just come on today to talk to you a little bit about stretching, mobility, and the benefits of it. And then there's a couple of questions on Emmett's post earlier on as well, that I'm going to just briefly go through. So I'll try and keep it short and sweet. I'm a big fan of stretching and I'm a big fan of mobility. For anyone from the everyday warrior right through to performance athletes, it's really useful for tackling office job symptoms that come up, repetitive strain injuries, acute injuries, and everything in between. So I think really with stretching, what you're trying to achieve is you're trying to either prepare before exercises or help reduce soreness and increase recovery for afterwards. So if we take stretching, static stretching first, the best thing to do is if you're thinking about doing it before exercises, just have a warm up 5 to 10 minutes, like jog, do a little bit of a mini hit session, anything to get your blood pumping, and then you can do your static stretching afterwards. And really, you're just looking at the muscle groups that you're going to primarily use during that activity. So for runners, you've got either foot or ankle, calf, you've got your quads and hamstrings and your glutes. And you can do all those in standing, one foot in front of the other for split stance, hamstring and calf. And then you can do bent knee, standing on your single leg for your quads. You can also do like a modified sitting down hip stretch as well. And all you're trying to do is increase your short-term muscle length, increase your blood flow, and then prepare that muscle for the activity. It'll help with your recovery later on, and it also kind of just helps your brain up into taking some tension or trauma through that muscle. It kind of just prepares it for that. So then for post stretching, what works really well is looking at like global stretching rather than just stretching static muscles by themselves. So something that works really well there is going through a full range of movement through the joint. So you've got your bigger movements like your lunges, you've got your heel raises, you've got your squats. You can do shoulder exercises in standing, just weightless, and it's going through your active range of movement. So you've got your flexion, extension, external rotation, internal rotation at different angles. And then you've got your back and your hips are always really important. So for gym-based classes, it's important to stretch most muscles, say afterwards, but trying to do a lot of muscles at once. For running and things like that, you can do specific muscles. And the benefits are really just for post-exercise, you're trying to prepare your recovery straight away so you recover faster. You delay or reduce your DOMS, your delayed onset of muscle soreness for the next day. And for your recovery, then you're trying to just increase that range. So for stretching, that's really as far as I go with stretching. It's a nice adjunct to have, um, but don't overkill on it. It's something that can help you, but you don't have to try and recreate something straight away. So mobility is really, really important as well. Like if you think about runners, a lot of the times they're stretching their calves or their hamstrings and they don't look at mobility. So even if you're just doing a straight line thing, you can mobilize or stretch your hips through different ranges, and the same thing with your back, and it really reduces your range of or your risk of injury. And it's the same thing in class-based scenarios as well. One of the things that the guys at Rushe Fitness always do is bring that shoulder through a mobile kind of scenario. So it's preparing that joint for action, and it's the same thing at the end, and it really reduces your risk. And the key areas to look for are your hips and your lower back. Hip mobility and back mobility really lowers the risk of hamstring injuries, of low back pain, protective tone, and a whole lot of other stuff. So going through mobility stuff, it's really important for that joint to try and regain full range and teach those muscles then to kind of react, and it protects your joints and everything else like that. So I'm going to spend most of this time going through these questions. So on the post earlier today from Emmett, we have some questions. So a lady wrote in saying that she was recovering from slipped discs and nervous about training. So she was improving or is improving, but nervous about training. What are good exercise and stretches for the back that I can focus on? So that's something that we see a lot of in physio clinics. Back pain, discogenic pain, slip discs, and probably from the more experience you have in it, the things that stand out with that, generally for 99% of the population with that injury, the initial acute injury itself actually is short-lived. A lot of the times within 2 weeks, that injury itself can repair or heal or get much better quite quickly. And a lot of the symptoms that you'll be feeling after that injury or event is your body adapting to try and protect you and move you in different ways and give you pain as a response to try and stop you moving or protect you. So with disc patients or acute low back spasms, any of that early acute frightening large event, it's really important to try and teach that back and hip to move straight away. So you wanted to move the joint to mobilize it, you want to stretch those tissues to make their function improve, but you also want to put that area through some gentle and progressive stress so that you do get a little bit of ache or pain out of it, but not overwhelming, so that you're teaching your brain that movement in that area is fine and you can calm down and dampen down your pain response. So simple things with that slip disc stuff, or in sitting you've got your pelvic tilts. So sitting up straight, hands on your hips, and you're either flattening your back or rolling your pelvis backwards and pausing, and then inhaling as you sit up straight to arch your lower back. And what you're trying to do is at the bottom of your back, you're trying to hinge and move down around your pelvis where that meets your spine, rather than just bending forwards with your chest. So that's a key thing, and it's slow. You're not trying to strengthen anything per se, you're just trying to get movement into that area to mobilize the joint, to stretch the tissues, and to teach your brain that movement's okay, to dampen down your pain response. So that's one of the first things that we go through. The second thing that we go through generally is hamstring stretches. So for a lot of people with that acute pain, they're most comfortable lying down on their back. So head supported on a pillow, you're lying flat on a firm surface, and then your knees are bent to 90 degrees. And what you want to do is you want to bring one knee to your chest using both hands to pull your knee into your chest as close as you can. And that's where you're going to start. You've gone 10 seconds making sure you're breathing in and out, and then you're just stretching your hamstring afterwards. So in that position, you're just straightening your leg to stretch your hamstring. If you bring your toes back towards you, you'll stretch your sciatic nerve as well, and that's a good thing because it'll help desensitize the area. But that early movement, and then you've got either your hip or your hamstring stretch to start with, just those simple things, and trying to do it maybe 3 or 4 times a day, plus slow gentle walks, whatever your capacity is. That's kind of your go-to for that kind of slip discs. And once you feel stronger, then you can progress into stuff, and likely that will be within say 5 to 7 days. You can move into like different movements after that, but start off with that. So the next lady was help with extremely tight calves and injuries in both feet, which don't help. So again, especially for Letterkenny, the amount of runners up here is phenomenal, and the amount of really good runners is through the roof. There's so many great clubs, there's so many different classes, all those adjuncts are kind of here for runners. There's so many couch to 5k groups and progression from there. It's really, really good to see. But along with that, we see an awful lot of calf tears, calf injuries, Achilles problems. Tight calves, a lot of the time with tight calves, you're doing something in running. So from experience with this, a lot of the times you can get calves rubbed out, it's agony, and dry needling. You can probably stretch it, although I imagine you've done all these things if you've had it that long, and it'll either reoccur or it'll never really go away, and you'll be limited within distance or intensity or duration or something like that. So a lot of the times with tight calves, you're not running well, and you're excessively using your foot and your calf as a result, like you're doing heel raises and running. So it's more or less like you're compensating with your calves, and your feet are pumping down to try and push you forwards. So you're probably going to be a heel striker, you're probably going to be heavy on your feet, and you probably don't move through your hips an awful lot. And a lot of times with those tight calves, you're not moving your hip like a pendulum, and you're not using your glutes and your hamstring to slow you down as your knee comes forward, and then really push you through with a forceful action down into your foot. So a lot of the times with your ankle and your calf or your soleus, it should be like depends on the runner, but a stiff, springy surface that allows you to transition that energy from your hip to the ground. So those tight calf patients, generally you're looking at hip mobility stuff. So like a large lunge, and then just moving your pelvis forwards and backwards, forwards and backwards. And then in standing, just high knees. So standing on one leg, let's say standing on your right leg, raising your left knee as high as you can. It's going to force that calf on your right side, your hamstring and glute, to push you up as your left knee is coming forwards, and pause in that position for 10 seconds, and then try and do 30 or 40 of those alternating legs. And when that seems to get a little bit easier, then you're just going as fast as you can, alternating your legs with no pauses. And that's kind of an easy thing to go to for your hip based stuff for your calves. With the injuries in your feet, if it's plantar fasciitis, there are specific things you can do for that. It's a horrible thing to get. Or if you've got any of those tendon issues around the arch, your Achilles, your big toe, there's specific things you can do for that as well. But the number one thing would be either to get someone looking at your running, or to get a running assessment, or start with those hip-based strategies for your calves. So the next lady is piriformis syndrome, and been ongoing for a while. So lady, so piriformis syndrome, sciatica, glute knee tendinopathy, hip flexor stuff, groin problems, they're all kind of like this syndrome area around your pelvis. And generally, whichever one you have, you're going to have a weak pelvis, and you're going to have a weak, kind of overloaded lower back because of that weak pelvis. So with piriformis syndrome, you're generally looking at strengthening your pelvis. So you've got your go-to core exercises, and you've got your bilateral stuff as well. But really with that piriformis syndrome, ideally what you're trying to do is differentiate between, is it sciatica, is it a hip problem, is it a low back problem, is it a stomach problem, and trying to figure out what that is. Sometimes what seems like piriformis syndrome could actually be something much more simple. But you're looking at strengthening your hips generally with that. So you're looking at specific stuff, say for your lateral hip, your say your side lying plank, and then the top arm is up over your head, and then the top leg is straight, and then you're raising that up and down, say 20 or 30 times. So you're using opposite hip for your lateral hip stability, and then you're looking at doing stuff like one knee against the wall, bent up to 90 degrees at your hip, and then you're doing mini one-legged squats on the opposite side. They're kind of your go-to for that hip strengthening stuff. And then looking at what you're doing, are you training? Is it repetitive stuff? Are you overtraining? Have you got a good training program? Is it when you overload it gets sore, or a long day at work? And trying to figure out those things. But looking at lateral hip stability or strength is probably your go-to first for that. But figuring out if it is piriformis syndrome is also important. So what treatment exercise can you do for plantar fasciitis? This is surprisingly common as well, and getting more and more common. So with plantar fasciitis, again, differentiating between, is it you've got your big toe tendon that runs from your big toe going back into your heel and up into your calf as well. A lot of the times plantar fascia stuff can actually be on the bottom part of your foot, just that tendon. If it is the fascia itself, a lot of times you'll have a heel spur, and you'll have like micro tears, and what will happen is that is almost like a ligament, or a thick piece that structurally supports your arch, and over time it'll be overloaded, and it can be from not doing anything in particular. It can just be life, but what you're looking at doing is trying to figure out, is it thick and tight, is it inflammatory, so what stage it's at, and then trying to pick out what you need to do. So if it's acute and early, you're looking at kind of aggressive calf stretching, calf strengthening, foot on a towel, curling your toes, and you're looking at trigger point release on the arch of your foot. So if that's my foot, then onto the arch, about halfway down, at maybe half an inch of diameter, you're going to find like a nice pool of trigger points. So with your leg crossed, foot on your knee, you're looking at trying to get those trigger points with your thumbs and holding it there, which will probably be quite sore until it dissipates or until the pain resolves. And if you're spending 5 minutes doing that, then you've got a bucket of cold water with ice in it, and then popping your feet in there for 10 or 15 minutes afterwards. That's your go-to for kind of that area. Strengthening wise, sitting down on a chair, feet flat on the ground, going up onto your toes, so you're on the balls of your feet, and then slowly lifting the balls of your feet up so that you're supporting the weight of your legs on your toes, not letting the ball of your feet go down again. You're pushing down onto your knees, and that's making all the small intrinsic muscles from your toes up, including your fascia and your big toe and your calf complex, all work as a team. And then that's kind of a good place to start with. With that exercise, you're looking at trying to do it 2 minutes 5 times and doing it 3 times a day. Works really well for plantar fascia, very, very hard to do, and the longer you do it, the more benefit you get, the more change you get. Hope that helps. So who else have we got? We have the best exercises for dodgy knees. Everyone has dodgy knees at some stage in life, I feel. It depends on what it is. If it's a stiffness and ache, non-specific, a lot of the times you're probably looking at knee mobility stretching. So kneeling on the ground with your feet flat behind you, and then you're just sitting back onto your hunkers, and then your hands are behind you, and you're just pushing your hips up to try and stretch your quads really. But if you do it kneeling on the ground, pushing your bum up with your hands behind you, it's a really good one to stretch over your knee joint. It won't really stretch higher up into your hip joint because your hip joint's in neutral, but your knee joint will be through a full end range flexion point. So everything around that knee joint in the front that joins onto the kneecap or onto the knee and the lower quads will really, really stretch. So for non-specific kind of general stuff, sometimes a simple stretch like that can help with knee pain. If it's medial pain, if it's burning, if it's anything like that, if it's a sharp pain, you're probably looking at either tight calves specifically, so dropping your heels over the edge of a step and holding it for 2 minutes. You'll really feel your glutes working, strangely enough, it'll fire those up. Or you're looking at hip control exercises, so lateral hip strength exercises, or hamstring control, so your quads strong and your hamstrings are just tight. So, standing RDLs and pausing there, feeling the stretch on your hamstrings but not your lower back is kind of your go-to for that without knowing if it's specific pathology. So you could try those out. And then who else have we got? So we've got best stretches for after cycling long distance. So after cycling long distance, one of the big things that you're looking at doing is from your quads up through your stomach into your chest. So you've got like slings of muscle that start in one place and go through and cross over your midsection and then go onto the front of your thigh, let's say. And you'll have like an X going down the front of your body. And what you're looking at doing is trying to stretch along that pathway. So anything that goes from your quad into your stomach, crosses over into your chest, your pec major, into your bicep, and into your arm, you're looking at stretching all of those at once. So bent over cycling, you're going to have a lot of flexion in your trunk, you're going to have a lot of abs on all the time. Hopefully you're going to be leaning on a supportive trunk to push down through your heels, not overloading your calf. So you're looking at thinking what muscles are being used an awful lot, and then you're trying to stretch those or use the muscles that you haven't been using during that as much. So with cyclists, you're looking at abdominal stretches or rotational sideline stretches, and yoga poses and Pilates are really, really good for that. Then you're looking at those slings in the front really. So you're looking at on your knees, holding a 2 kg weight and pretending you're taking a sword out of your pocket and rotating with it to the opposite side and trying to let your pelvis move forwards. You've got extension happening in your spine. You're pushing your pelvis forwards to stretch that rec fem, your quad up into your hip into your pelvis, and then you've got your pec major as well. So the really good thing about that is you're using the opposite muscles in the back as well. So for cyclists, a lot of the times they'll end up having neck pain or low back pain or hamstring pain because they've taught their brain to stop using the muscles on the opposite side. So if you're training a lot of chest stuff, one of the best things you can do after the gym is pulling on those bands against something in front, like Emmett always has you doing, or Peter always has you doing. And it's the same thing with cyclists. Think about what you're using, try and stretch those, don't kill them, and then think about the guys in the back that you haven't used as much. Just do a little bit of light work on those and you'll feel so much better. So that's cyclists. The next one is dropped arches in both feet and bad posture, giving hip and lower back pain. Walk the next slide every day, but on feet 12 to 14 hours a day. And there's proper fitted insoles, but is there anything else you can do? Dropped arches, that's a really common one as well. So we work with some podiatrists around the northwest of Ireland, and we have a really good relationship with them. That sometimes with those patients they might present with dropped arches, but it's not as much a structural thing, so they might need a lighter insole but a lot of stretching perhaps, or maybe it's just specific strength stuff. Or sometimes we might have a patient where they probably won't get away with doing stretching or stretch just by itself, and they probably do need a structural thing from orthotics. So, but generally you're looking at doing both, and it's really important to have both doing that. So one of the things about your feet, they're designed to kind of like pick up as you take a step, land on your heel and fold out. So fan and fold is what it's meant to do. When you put in something structural there, the first thing your brain will do, brilliant, this is fantastic, I don't need to do anything. Switch the foot off and stop using as much as you can. You've got your structural support, and that can lessen symptoms initially, but generally over time it'll cause problems elsewhere, either specifically in the area or higher up that kinetic chain. So with that dropped arches aren't always bad. Sometimes you can be moving really well. So some of the best runners have terrible looking arches, but they perform amazingly, and their ankle is really, really nice and stiff and uses like a spring, which when you see them first, you think, God, you'll need something done about this. So probably trying to whoever you've got the fitted insoles from, trying to maybe get an opinion on that, which one of those categories you're in. But generally, that same plantar fascia exercise where you're sitting in a chair, your feet are flat, and then your both feet are going up onto your toes, you're heel raising, you're on the balls of your feet, and then you're just gently lifting the balls of your feet up, so that your toes are now supporting your leg weight, and then just leaning down on that. And again, it kind of is just a double whammy of getting everything in there. You've got your digitorum, the toe muscles, you've got intrinsic fust muscles, you've got your plantar fascia, you've got your big toe flexor, stuff that supports your arch, your tib posterior, and your calf complex. It's a nice easy one to do for that. That's probably your go-to for that. And then apart from that, you've got proprioceptive stuff. So standing on a firm surface for 2 minutes without falling over is your kind of like your gold standard. Standing on a foam mat, a cushion, anything that wobbles, again, your proprioceptive stuff. And then your single leg heel raises, something that'll probably work well with you if you've got dropped arches, is a rolled up towel under your toes so that your foot's flat on the ground. And when you go to a single leg heel raise with the rolled up towel under your toes, the ball of your foot is still on the ground. So it's just kind of making your arch wind up as you go into your heel raises, and then doing excessive amounts of that at the start. 30 or 40 is kind of what you want to aim to, and you've got 3 sets of it. So at the start you'll probably get to maybe 8 or 9, and then in 3 to 4 days you'll be up to 14, and you slowly just build up. And every time you do a set, you're trying to get as many as you can, but the goal is to get up to 30 or 40 depending on your age with that. So trying to find out why or what kind of arches you have, and then your plantar fascia exercise or those heel raises with a rolled up towel under your toes. We have someone asking, any advice for a body that cracks a lot? Absolutely not. Completely normal. The only thing you need to watch for is if you had a joint that cracks and has a sharp pain and has lingering pain afterwards, I think that's probably something that you want to get checked out. But in terms of cracking and popping is just a really healthy, normal, everyday thing that generally increases as you age. Um, so generally with a joint, you'll have your synovial fluid in the middle, and you'll have different things that pass through the fluid, and your cartilage acts like a sponge, sucks in all the stuff that it needs to, and it helps lubricate the joint with nice synovial fluid. But sometimes you'll have a buildup of gas within that fluid, and as you push your joint through it and roll through it, kind of like those plastic bubble wrap things, it'll just pop a gas pocket, and that'll just disperse then throughout the fluid. And a lot of the times that's what cracking is, and it's healthy, doesn't cause any harm. The other place you'll get it in the front of your kneecap, where you'll have like sandpaper feeling or crepitus. And as you age, you kind of have two parts of cartilage. One is a really shiny hydrophobic part, and it moves without any friction at all. But you can lose that as you age. So some people it's from 30 up, some people it's from 50 up, and you'll start to hear that. But again, that is generally okay. It's not usually a sign that there's anything bad in it. So cracks are healthy. So I wouldn't advise anyone to crack their joints, but don't worry about it too much. So then we have somebody asking about a knee with a partial tear of the medial collateral ligament, mild lateral tracking of the patella, and Osgood-Schlatter's disease. What would he advise? So if that's Osgood-Schlatter's disease, if it's an active form, then it's probably going to be a child between the age of 8 to 14, 16 max kind of thing. So it would be unusual to see a child with a partial tear of the medial collateral ligament, and probably not lateral tracking would be more common. Usually with kids it's more excessive elite sport, and ACL seems to be the big problematic recurrent injury. But so if this is an older person, then say over the age of 18, the Osgood-Schlatter's could be in an older form, which isn't live anymore, but still could be given a tendon pain at the front of their knee. Partial tear of the medial meniscus or medial collateral ligament. Let's take that first. So you'll have kind of three sections of it. So as your knee goes through your range of motion, if you had, so you're on my inside knee, part of my right knee, your medial collateral ligament goes over there, and it helps stabilize that joint, so that joint can't really buckle in that direction. So if someone pushed me from this direction, it stops it or limits it with other things like muscles. But with that medial collateral ligament, you'll generally have like pivoting on that leg, turn into the opposite side, and someone will tackle, or you'll trip and you'll overstretch it. So because your knee has so much movement from straight up to wherever your knee bends, for that ligament to work in all different angles, it has to have three parts, and one part will operate more when it's straight, and let's say the opposite, the third one will operate really when it's bent. So trying to find out which ligament it is, it kind of depends on that. A lot of your organized rehab for it, but you'll have different grades of ligament tears. One is just like a really overstretched ligament. Grade 2 can be either overstretched or micro trauma. Then you've got 3, which there's definitive tears on an ultrasound or an MRI, and then you've got different stages after that you don't commonly get unless it's a high impact, kind of like professional sport, usually AFL. So if it's grade 3 and above, a lot of the times you'll have to brace that knee. So you've got a brace that has a mechanical hinge on that inside part that offloads that knee, and it's the last thing you want to do generally, and it's usually dictated by pain and orthopedic tests that a physio can do on you. So whenever I have someone in our clinics with an MCL, you're ruling out if it's your groin that attaches on that inside part of your knee first, because sometimes it can be that's generating your pain. You could have a grade 2 MCL tear, but it could actually be your groin, your adductor or gracilis that actually, or even your hamstring, that generate your pain. So it's probably trying to figure out, again, your differential diagnosis on it. Sometimes people can come in with imaging scans and they go, here's my problem, and sometimes it's not that. But if it's really for the painful part, if it's notable when you're walking, sitting to standing is almost doable and almost not doable. If you're standing and you make any kind of turn, you get weakness or a sharp pain. And if you feel unstable, that's generally what a patient will say. That's kind of like your grade 3, very symptomatic, painful patient that you'll have to put on a brace for 6 to 8 weeks, or 4 to 6 weeks if they're not as bad. And you're just looking to brace that knee, let the ligament not get stretched again for that time frame so it can heal well, with different types of collagen. And then you're looking at just simple rehab exercises from your ankle, knee and hip up, with the mild lateral tracking of your patella. That's really, really common. Generally with that you'll have lateral hip pain, weakness, or you'll have a pelvic dysfunction. So you'll have tight hips or weak hips, one of the two, sometimes together. With that kind of stuff, then you're looking at a lot of the times just hip work. So you can get dry needling on your VMO, the inside part of your knee. You can get soft tissue massage, and you can get passive stretching. But with that kind of stuff, the first thing I'd look at doing is trying to make you use your quad. So in hamstring early rehab things, you'll have Nordic curls. So you're on your knees, you're straight, and then you're holding a weight as you're leaning forwards, and you're using your hamstrings to stop you leaning forwards. And one of the things you can do for your quads is kneeling down with your feet flat and then up straight, keeping your hips in neutral, slowly leaning back to take the weight on your quads. And you won't get far. You'll feel that stretch and you'll stop when it gets to its weak point. But you can start doing that, and you have a very, very small range at the start, and it'll be very severe, but it'll strengthen. And the important thing about that is they'll lengthen under tension. So as you move back and you've got weight on that muscle, you'll stretch and kind of rip it apart in parts, but that will help lengthen it, and it'll give you a bigger strength range, or a range that you can have capacity within. So quad stuff, lateral hip strength, and then single leg stuff afterwards once you get control for your mild lateral tracking of the patella. And then Osgood-Schlatter's disease, if it's your acute active phase and you're a kid, they will grow out of it. The one thing that you need to watch out for is overtraining or training that leads to pain. So that has to be reduced. Again, the last thing you want them to do is stopping. You never really want any athletes or anyone else stopping, but trying to limit it. And that's probably the biggest thing for Osgood-Schlatter's, is manage your pain, know what your capacity is and work around that. And then you've got ice directly on the area, on that knee tendon on the front. So you're looking at having frozen packet of peas, like a wet kitchen towel down first on the skin, frozen packet of peas on top, and trying to have it on there for 20 or 30 minutes at a time, and trying to do that twice every evening for 2 weeks. And then that should start to dampen down your inflammatory phase and your painful phase, and then you're in a phase where you can kind of just regain your load. But again, you're looking at low back strength, core strength, hip strength, and then co-contraction of your quad and hamstring for just that control. Anything that you can get stronger around that area will help ease off that area. So I hope that helps. What else have we got? Any advice, recovery stretches for spondylitis? That's a tricky one. If it's confirmed, it's a tricky thing. Ice generally, and either insoles. If it's very acute and painful, you've a better chance of ice and offloading it, either with tape underneath that big toe to support your arch more, or insoles. But generally ice and something soft, so like soft supportive runners that limit the pressure that you put down through that ball of the foot underneath that big toe, or a foam insert that you can buy in Boots or on Amazon just to cushion that area. Again, you're not getting trauma directly up onto it, but ice and offloading is going to be your best friend at the start. If it's a chronic thing and it's been there for over 6 months, or it comes and goes for the past 5 years, you're probably looking at either really severe stretching on your calves. So rolled up towel under your toes, foot flat, pushing your knee to the wall to try and stretch that big toe tendon, your plantar fascia, your calf, or dropping your heels off the edge of a step, just single leg at a time, 2 minutes, and really stretching that out. As long as you can put pressure on that. Or the other thing is then going to be just orthotics. Again, podiatrists trying to get their opinion on that if it is chronic. But ice and stretching and strengthening, and that's probably your go-to. So any ideas for pain on the outside of the knee extending down the front of the shin? New onset, yeah. So with that, it probably sounds like it's going to be like an IT insertional area pain. Lateral meniscus can present like that. Generally, it'll be at the back corner, that posterior horn. But so with that kind of stuff, foam rolling is probably your go-to with that. So foam rolling on that IT band, so up the side of your leg. If you went to the middle of the side of your knee and the bony bit on your hip, and you drew a line down there, that line, and forwards and backwards on that line, up and down with a foam roller line on that side, it will be agony. But you want to do that foam rolling with your leg straight but relaxed, trying not to protect yourself. You want to do it with your knee half bent, and you want to do it with your knee bent as much as you can, because the straighter your leg is, you're going to be predominantly getting that IT band, which is good if it is that insertional thing. But what's underneath that IT band is your lateral quad, and your lateral quad goes from the side of the front of your thigh the whole way back to your hamstrings. It's almost like a flat muscle, and it lives underneath that IT band. So the more your knee bends, the more you'll get at that lateral quad, and both of those will be going down to the same area. So IT band foam rolling, but also with your knee bend foam rolling, which will be good. We've got someone else. Any advice for really good runners with excellent support for a heavier woman that's training? Okay, so what type of runners to use? So you need to know, are you a heel striker or a forefoot striker? More than likely you're going to be heel striker with that. So you're just looking for supportive runners. So Brooks are nice and light and supportive. I'd say probably the runners that you're probably going to go to first are Asics, because they'll just dominate and give you huge support. They'll probably be clunky and stuff like that, but for what you need at the start, which I think you might be getting back into running or trying to progress your running or starting off running. So with that thing, you just want to have something that makes your foot take support for that starting place. So get into running, get those tendons and joints and ligaments and hips and muscles used to taking that load with support. And then once you feel comfortable and you feel, you know what, this is a lot better, I can do my running now, I feel like I can train a bit more, then what you're looking at is starting to either reduce your supportive wear into something that's specific for you. So you'll be if you feel like that, you're going to be like an onion at the minute, and everything's going to be tight and sore, and you'll feel like you need really supportive runners. And the more you run with supportive runners, the stronger you'll get. And when you get to that stage, you actually might need less support or something more specific. And then at that stage, there's a really good running shop. You've got Michael Murphy's or McCormick's in Letterkenny, or in Sligo there's Run Pod. They've got a website as well, and the guy that runs that is John. So runpod.com, I presume, or runpod.ie. If you go on their website and send them a message and say you were talking to Patrick at Physio, John will probably advise you over email or even over the phone in terms of what they have. They have probably the largest selection of runners. So obviously it's not a good thing with COVID limitations, but even something like that could be useful. But start off with you're probably going to go down the Asics or Brooks stuff, and then see where you are in 6 months of decent training. So we're near the end of this. If you have wee niggles in your knee and elbow when exercising, not major, should you see a physio or just exercise through it? So that's a tricky one. So if there's small and general aches, you might be okay. But if it's something that's making you worry or think, is this something bad? It's probably better to get it checked out. Better off to try and tackle that stuff before it turns into something big, I would imagine. But chatting to Peter or Emmett or Maria, they are kind of experts in terms of the gym-based scenario. If they think it sounds like something that's not bad, then it's going to be easy. If they think it sounds like something that needs to get checked out, they'll advise you on that. So they're really good points of contact to try and use. So Emma's saying that that'll be the last question, so that means I'm free. So hopefully I haven't bored you guys to death with my rattling on. They're really good questions, and if you've got any further questions, either you can ask for our details from Maria, Peter or Emmett, or go on Fix You Physio on our Facebook page, and we're always available to hit you back with a message as well. So hopefully that was useful to everyone. Hope everyone's doing well, and we'll talk to you at some stage.